Problem solved.
I think that this bill addresses specific days, but I'd be happy to do that work session because I'd surprise you on my position on some of these issues.
Sure. Okay.
So I was going looking for my face. I'm good. How are you? I'm looking to say, Brent, thanks for being here. I will not accept your commitments to our bill. Pardon me. I actually do.
Sir, for patrons. Well, I am a patron.
Well, let's say. No, I do about 25,000 stuff.
Unless you're running.
Yeah, no, I'm not. No.
So you'll have to let them know. Oh, is there signage? Let me find out.
Yeah, they're typically.
The other thing is when they find you, they kind of get a seat.
Yeah.
I stay away from that.
But yeah, so if somebody wants to see, there's like a really camera state of being.
And then they locked me out. I went downstairs.
Well, we're going to have everybody. We're going to listen to everybody.
I just didn't know if there was an order.
Well, like I said, I have my dog walker come take care of my dogs between 4:30 and 5:30, and as long as she fed them.
So we do not have a quorum yet, so we'll be at ease, and y'all keep talking quietly amongst yourselves. I just wanted people to think that we actually do things timely here, not we're just sitting waiting and yada yada. We'll get a quorum and then we'll move forward.
Saturday morning. I'll be a little smelly because I canceled that. I did cancel that. So I've got spin class at 8:15, but I'll just like put my hair in a ponytail and change to a different shirt, I guess. Oh, people will be judging. I'm very good at spin. Like, I'm usually the #1 woman in the class. Not to brag, but you know. But also that results in me just like leaving with like an extremely red face and just being like, you know what? This is embarrassing. We've won.
And winning's also good.
Yeah. Well, it turns out that actually, like having gone to class and experimented on different bikes, I'm like, oh, it really is all about which bike you choose.
I believe that too.
So the important thing is to get the good bike.
Just like you gotta come here to get the good seat.
Yeah, exactly. That's what kind of bad. Like, well, I did offer the seat to Swillman and Blue, because it has all the different like replacements. You know, the other.
All right, good.
So I'll put the speaker. And she said no.
All right, I'll try to speak loudly today because we do not have amplification. And I would ask all of the respondents and all of the patrons, just speak loudly. There are a lot of folks that are out in the halls and so forth, so I want people to understand and hear what we do. A couple of cleanup things first. If you are here to have a conversation about Delegate O'Quinn's House Bill 2223, dealing with pharmacies and delivery of prescription drugs and pharmacy benefit managers, or if you are here to discuss and hear about Delegate Pillion's House Bill 2561, dealing with pharmacy audits and pharmacy benefits managers, I have letters from the Speaker of the House. Those bills are going to be re-referred to the Commerce and Labor Committee. So they will be sent up to Commerce and Labor from Health, Welfare, and Institutions. I didn't lose half of the audience. I was hopeful. If you need to leave, that's fine. Why don't y'all go ahead and... How's that what? Is that an amplifier? Is it working? Yep, good. Are we somewhat amplified? Yeah, y'all can hear us there. Okay, good. Alrighty, we're going to go with this. So this evening has the opportunity to get... So ladies and gentlemen, I really need folks to just hang with us. It's very noisy out there. It's hot out here. It has the potential to be a long evening. Everybody's tired, and we really need to have folks focused. There's a lot of very important issues to discuss today, and I really want to make sure I do it justice so the chairman doesn't give me grief next Tuesday when we present these bills. So if you all will hang with us, I appreciate that more than you can know. So let's see. Delegate Torius, I draw the committee's attention to House Bill 2472. Good morning, sir. Afternoon. If you would tell us why we need your bill, Delegate, and what your bill does, please, sir.
Okay, House, and I have Mr. Chairman substitute.
All right.
In committee, I'm going to share with you the summary of my bill. House Bill 2474. It directs the Department of Medical Assistant Services to develop.
Hey, Delegate, I'm sorry. We
Bring the substitutes back.
Passed down the wrong ones.
My apologies.
Replay.
We never saw it. All right. Sorry, grabbed the wrong one.
Good year. I like it.
Ruin that record.
Cupcakes. You learned how to chop or eat a cupcake.
I need one more. I got we're good.
Yeah.
All right. Delegate.
All right, Mr. Chairman. House Bill number 2474 is to direct the Department of Medical Assistant Services to develop and implement an expedited review process for applications for community or institutional long-term care services for individuals diagnosed with a terminal condition. Let me share with you how this bill came to me, Mr. Chairman.
Yes, sir.
I had a constituent in my community who had been diagnosed by her doctor with a terminal illness. She was to go to the health department in order to qualify for long-term care. She was diagnosed in December of 2015. She received her appointment in February 2016, and in March of 2016, she passed away. She had to wait over 30 days in order to be seen. And what we would like to see take place is for DMAS to cut down on the time frame that an individual is seen when they have been diagnosed with a terminal illness.
All right, members understand, so basically today DMAS has a 30-day obligation to screen someone that's diagnosed with a terminal condition. Delegate wants, because he had a constituent, DMAS didn't comply with the 30 days, he wants to move to 10 days to send a clearing and compelling. Is anybody here from DMAS?
Who's this there? Who's down there?
I understand. Yeah,
Do I need to go back?
come on forward. Good evening, sir. Have you had a chance to speak with Elliot Torian? Do you understand his issue, concerns, his constituents' concerns?
I'm sorry, I couldn't hear anything out in the
He
hallway.
has a
I'm Brian
constituent,
McCormick, I'm the policy
Brian, thank you very
director.
much. You have a constituent who was diagnosed with terminal illness, applied for DMAS. Supposedly y'all have a 30 days to screen them, and it took months to screen them. Is that a regular and frequent thing? And he's asked for us to basically send a clear message to you all that's unacceptable, and he wants to decrease your day from 30 days to 10 days that you're required to screen them.
I understand the bill, sir. That is, I would say that is an unusual occurrence. I don't think we have, for terminally ill patients, I don't believe that's the usual course.
All right. Members have any questions? Thank you. Any members have any questions?
I think so.
Anyone in the audience to speak in favor of House Bill 247? What is proper posture? Could I get a motion on this amendment?
Second.
Without objection, it's properly before us. Anyone in the audience to speak in favor of House Bill 2474 as amended? Yes, ma'am.
Dr. Derek, committee members, Marcy Tedderton with the Virginia Association for Home Care and Hospice. We'd like to thank the delegates for putting in a bill to expedite Medicaid, long-term care, eligibility requirements for people with terminal diagnosis. As he said, these are folks that have been certified by a physician to have less than 6 months to live, and if they need long-term care services, we want the families to be able to receive those so that they can care for their loved ones.
All right, thank you very much. Anyone else in the audience to speak in favor? Anyone in the audience to speak in opposition to House Bill 2474? All right, if not, the rest of the committee, and I would, although we don't have a fiscal impact statement on this, we're basically gonna have, I suspect, an impact to DMAS. Yes, sir, Eleonora.
Mr. Chairman, to that point, could I have the gentleman from DMAS come back forward, please?
Yes.
Two questions. First, if this goes forward, what are the FTE implications or subcontracting cost implications for y'all to comply with this new mandate of 10?
Most of those would fall on the local DSS offices. For DMAS, there would be some administrative funds needed for system change, and that would be the same for DSS as well. We would have to change our eligibility enrollment system to accommodate this change. The bulk of the requirement would fall, however, on the locals, so that they might need more FTEs to hire the expedited workflow.
Mr. Chairman?
Yes, sir, Eleonora.
And maybe the more practical implication, you didn't comply with 30 days and there's no penalty. Delegate, my concern is if we make it 10 days, what changes?
Perhaps there should be a penalty associated with it.
I was kind of thinking that too. I don't know who you penalize is the challenge. Mr. Chairman, if one thing further.
Yes, sir. Mr. Chairman.
From DMAS, all right. I completely understand, this is the outlier. But can you share, how can something like this happen? In so much as, 30 days just seems generous right now in time to be able to see somebody for their screening.
Well, I know that there's different parts of the year where there's a much higher volume that could have happened during that time. I can't explain this one instance that's being raised here. We have expanded our capacity to do screenings. We were enabled by the General Assembly, I believe it was 2 years ago, to contract with other agencies and other providers that can do the screenings. We've implemented that, and we've had good success with that. So we do have federal oversight on issues as far as timing of screenings and enrollments and that sort of thing, and those do end up in penalties for the state down the road.
Well,
Eleonora.
would it, get you kind of where you want to go with? We didn't go necessarily with the 10 days, but we added to this section a requirement that the department shall report to the governor to the Secretary of Health and to the Chairman of HWI and Senate Health and Ed, on an annual basis, any circumstances of any, just on an aggregate number of times they were unable to comply with the 30-day mandate. And frankly, I think, Ms. Chairman, in all candor, that might be more effective. If we know the gravity of the problem, if the department has to tell the governor, the law says we got it, I think that might get people's attention more than just saying 10 days, and if you don't comply, nobody knows about it except the poor folks that were victimized. So,
Think about that for a second. Delegate Roberts.
Mr. Chairman, I just have a question for clarification. And this probably might go to council. And is the code section 32.1-123, is that where it says that it's terminally ill? Because I don't see any language in here that says that person's been diagnosed with terminally ill, and only plans, well, and they only live for 6 months. It was in the original, but I don't see it in this, so.
Council.
One moment. So this is the definition of certified nursing facility. At the time, you looking at line 14 of the substitute?
Yeah, and
That's, so that section is the department shall require pre-admission screening of all individuals who at the time of application for admission to certified nursing as defined in that section. That's looking at that, that's talking about the, definition of certified nursing facility.
So I don't see anywhere in here where it says that they have been diagnosed with terminal illness in that substance.
May I,
Yes, ma'am.
Delegate Garrett, may be able to provide some clarity to this. This is under statute called the pre-admission screening process for nursing facilities, but it also is either for a nursing home or waiver services.
So we're moving away from just simply terminal conditions and anyone that's pre-screened to come into this.
Correct.
Okay, we got it.
Correct.
Yeah, Delegate Hart.
Mr. Chairman, I'm going to make a suggestion to Delegate Torrey, and let's get together and work on language, and I think the language would be to the point that anyone who is diagnosed with a terminal condition and was not pre-screened within this timely manner, that's something that needs to be reported. Mr. Chairman, I will suggest this is subcommittee take no action, but Luke, you and I will get together and I'll bring it to full committee Tuesday, which is when the subcommittee would have it come out anyway. So it'll come without subcommittee recommendation, but we'll work on language, because I think we need to know how often this type of situation arises.
And Delegate Orrick, this has been an ongoing issue for a number of years. I know you guys.
We got it, but we got it. We'll
DMS
work on
does
it.
collect the data, so they can.
But we don't know what we don't know.
I
Hang with me,
understand.
hang with me, got it. So what I'm hearing before the Uber chair is motioning that we take this 5 of the day, that he works with the delegate to try to get some language before full committee next Tuesday.
Second.
All right, probably moved and seconded House Bill 2474 go by. All in favor, say aye. Aye. All right, very good.
Thank you, Mr. Chairman.
Delegate Landis, you sat for 2.5 hours last night, sir, and listened to an inordinate number of health and welfare institution bills, and you actually seem to be pleased, sir. So, and Delegate Kilgore, you're next on this list. Go ahead, Delegate Landis. Yes, sir. Draw the committee's attention to House Bill 2457.
Mr. Chairman, Sarah has a substitute. Working with some of the stakeholder groups, I think they've come up with a good compromise position. What I'm attempting to do is to try to get doctors who have no longer been practicing back into practicing and helping more with direct care. And what the substitute does, Mr. Chairman, what we originally came up with was an inactive license, and the department had some concerns and questions about that. The Medical Society and others came up with the suggestion of the retiree license, which makes a lot of sense because most of the folks that are inactive are going to be retired docs. So what we're trying to do here with this substitute is basically allow them to come back into the practice. Would probably most likely be limited based on just how much time they want to spend. We don't anticipate someone going back into full active practice, but I do think a license like this could help hospital systems, free clinics, these other groups that are looking for doctors to provide some primary care, which we have a very big shortage and problem with the capacity that we've got now. So this is what we're attempting to try to do. I think the retiree license seems to be a good direction to go. It's a little different direction than I was originally anticipating, but I think it gets at the same issue and the same way. And Sarah, I think you've also got, maybe you've got an updated substitute that's got some corrections, but I think there was some.
I do not have that, but I think that there was some concern if we look at line 16.
Hang with me. So, yeah, we're getting ready to. So we have this substitute in 5633, or at the top left, 5633.
Yes.
Property. Anybody have a problem? All right. Without objection by general consensus, this substitute is properly approved.
And the line amendment is on line 16, at the end of this sentence there, where we say engage in the practice of medicine. Add the words osteopathy, podiatry, or chiropractic to mirror the language that you see up on line 11, just to.
Which is in A. So.
Everybody understands the amendment? All right. Without objection. All right. Landis. Everybody understand? Anybody have any questions for the patron? Yes, Delegate Price.
And I think I understand what you're trying to get for. I just wanted to see, with someone having been, Mr. Chairman, with someone having been retired, are there any implications of continuing ed or kind of education? If you could describe that more in depth, so that definitely they can get back into, practice, because we want to expand access, especially for those areas that have access, but we want to make sure they have access to quality care.
Well,
and I just want to speak.
Basically, with this legislation, I think they would not have to have all the same requirements that an active doctor would, because we're limiting kind of what they would be doing from a primary care standpoint. But obviously, if you're going to practice medicine, I believe the department, I think that's why they're more comfortable with this. There's certain things I think they can still require the doctors, even under this license, to do from a competency standpoint, and then also from the standpoint of additional training or the like. I think they're still going to be able to, through regulation, be able to determine that, because by setting it out in statute, my understanding is they would have to come back and do some additional regulations and rules related to that. I think we envision that they'll probably have some flexibility, but that's up for them to determine, I think, at this point. But the idea is to try to get them there. And I don't think, in talking to some doctors, I don't think they're going to be wanting to come back and doing this full time. That's not kind of what we envision. And we're trying to direct it to primary care, because that's less specialized. It's more general practice of medicine, which I don't want to offend the subcommittee chairman, but it's not like being a surgeon or something else. There are different practices and the like. So,
but to that point, though, we are basically saying any physician, anybody that's licensed by the Board of Medicine would be able to do so. Delegate Roberts, you have a question?
Chairman? So at the bottom where it says they just have to notify patients whether they have current malpractice insurance or not, is that, I guess my concern there would be who's held liable then if there's a problem? I mean, is it because the charity care, wherever they're providing that care, or the health services, where does that happen?
well,
So somebody's got to be held
I think
responsible.
if the doctor's is, I think the way I envision it, if the doctor is practicing alone, and that's not what we envision with this license, I think they'd be liable. So they most likely would go out and get their own. But what we do think with free clinics and other entities that allow charity care now with a retired doctor's license, or a practice like a hospital that may say, hey, can you come back and help? A lot of times those practices are already covering kind of under an umbrella policy those docs. At least that's my understanding of how it works generally.
To date, I'm covered under Good Samaritan. If I stop on the road and render care, I'm covered under Good Samaritan. If I go to the free clinic or any other facility with the intent of offering care, I gotta have full med malpractice, and that's the delegate to know. That's exactly the challenge. Is docs don't want to do that, because I have now that I'm retired, I have med mal coverage that covers me, because to the day I die, I'm still responsible for people that I would have operated on, particularly for children that I've operated on back
Delegate Landis, is there already restricted license?
There's, there's already the original bill, what we were talking about was an inactive license. There's already a voluntary license, which is a whole different aspect. But what we're trying to get at is somebody who hasn't practiced for a while or has recently practiced to try to get them back in if they're willing to offer that care, especially when it's the right property.
All right.
Yeah, I guess for whatever situation, Mr. Chairman, that someone might find themselves in as to where they would be needing charity care, I just want to make sure that we're upholding the integrity of the care. And even though it's not surgery, I mean, there are some very important things that happen within the categories that are listed, and I just want to make sure that we're maintaining that. And so I agree that, you know, the determination should happen through regs. I just want to know more about what those qualifications may be, and if there's a friend that can help.
Mr. Brown's here, or somebody from the department that I work with, but.
David Brown, Department of Health Professions, what specific question do you have?
I guess I just want to make sure if I'm coming out of being retired, how long can I have been retired for? Do I have to have?
The language of this bill would allow someone to transition into the status when they retire. So they wouldn't have been out of practice for 10 years. We worked with the Delegate Medical Society to draft this. So someone could continue on after they retired in this status, but they would be transitioning into the status when they retired. And secondly, they would, I think, answer a previous question you had. They would not have to satisfy continuing ed in the first licensure cycle, but after that, they would have to show evidence of continuing ed, just like any other physician.
So, Dr. Brown, it's not your intent that the state is going to indemnify these folks and actually going to cover their medical malpractice?
No, and that's why the line was here about if you don't have, I mean, there's actually no requirement for any physician to have malpractice insurance. Of course, it's generally a pretty good idea, but in this specific case, if you don't have it, you're obligated to notify the patient that you don't care about that.
And you're correct, there's no statutory requirement, but there's a practical requirement. If you're going to be a member of most hospital medical staffs, their policy is going to require it.
And just to answer one other question, make sure there's no confusion, this was written in such a way that it could be voluntary, but it also could be something where, as the delegate mentioned, a health system or a hospital may want to have someone who would be in a position to make house calls and follow up at home with patients in a compensated fashion.
So I absolutely agree with the idea of it, the concept of it. We got it. It's a very clever and creative way of actually trying to meet some of the need. And my Section 1 guru to my right may be working on a Section 1 bill to address this. But to that point, is there anyone in the audience to speak in favor of 2457?
Mr. Chairman,
Yes,
Scott Johnson for the Medical Society. I want to thank Delegate Landis for working with us and Dr. Brown and the department this morning. We think this is going to be a creative model and help with the workforce and access to care, so we ask you to support it.
So, Mr. Johnson, as someone who is very familiar with medical malpractice, how are we going to get folks like me that have been out of practice for 13 years? I want to go back and help. I ain't going to go back and put my family's entire economic net worth at risk for actions I might do now. How are we going to get folks to incentivize them to do that?
The three avenues come to mind. You've got a reporting endorsement from the professional liability insurance policy that you had when you were in active practice. You first are going to check with them to make sure if you do this volunteer charity work, you don't void that. The second thing is if a hospital system engages you to go out in the community and make house calls, you may likely have the ability to be added on as an additional insured on their policy. If you did it through a free clinic, you know, we cover that through our Division of Risk Management today. But if you choose to do none of that, that's when the last line would come in and you tell the patient, I don't have insurance, they have malinsurance.
All right.
Mr. Chairman, with that issue, I think we envisioned that most folks are going to take those first options. Probably not, as Delegate Robinson was saying to me kind of offline. I don't see and wouldn't think that many doctors that have recently retired are going to just go out and not have any insurance or would take that option because they would be basically facing what you just said.
And the sad reality is it costs me $52,000 a year whether I just take off one mole or I'm doing 780 cases a year. It's the exact same premium, sadly. Delegate Orr.
And Steve, to that point, because the only thing that gives me pause is this, that I said, Scott, you may not want to talk to me, but you're card guy.
Yes, sir.
I don't know. I have concern with this language saying, you know, If I tell him I don't have malpractice, that's all I gotta tell him. Well, I'm the only doctor he's gonna see, like he really has a choice. And he doesn't, you know, then there's an untoward outcome. And his family finds out that I was a retiree, I haven't been keeping up with continuing ed, you know, all these various things. Oh, no, by the way, I didn't have any malpractice insurance. That's the only part from a practical standpoint that gives me pause. I would rather, if that sentence weren't there, but rather there was a requirement, either individually or through the healthcare clinic or some other entity, that there was some liability protections. And that would be mandated that either on their own or they shall be a part of a group liability protection system. That to me, the bill is a lot more workable that way. Absent that, my thought is that maybe just better to make this a Section 1 bill. That I think we all embrace the concept. But to charge the department with addressing these questions in a more formalized manner, I should heard your preference.
Let me just say, they propose a Section 1 bill. Section 1 bills do nothing. I've been down here long enough to know that they really mean nothing. Either you like the concept, or it's workable from the standpoint of even dealing with the malpractice, or you're done. The problem we've got, Delegate O'Rourke, is we have got to find ways to get more docs in the system. With Medicaid, with private practice, folks that I talk to, if we don't start doing some things creatively, we're going to get behind the 8 ball. So this is one option for you. If you don't like it, that's fine. Or if you think there's a problem from the malpractice standpoint, I think, deal with that issue. But Section 1 bill doesn't really get it. I don't think it's going to change anything, between now and next year.
I will just say I know different on that, because all due respect, when I have an agency Section 1 bill, if they don't respond, they're going to see a bill shoved up their nose the next session. And I think that's
Mr. Chairman, if I could respond to Delegate O'Rourke, one of the things from a practitioner approach is all of our licenses generally are set in code, just for sake of ease for people to find it. If we did a Section 1 bill directing the department to do it, then that's not going to be in our code. So I would favor having that statute.
All right, sir, thank you very much. Anyone else in the audience to speak in favor of House Bill 2457? Yes, ma'am.
Discrimination.
Nicole Keeler on behalf of the Association of Free Clinics. And I just phoned a friend. And Linda Wilkinson of the Free Clinic Association says the facility does have its own medical malpractice insurance, and physicians each have their own that they purchase on their own. So just to clarify.
Mr. Chairman.
All right.
Well, that just begs the question, why don't we just require everyone to have malpractice insurance if we don't? Scott, do you have a problem with that, Scott?
I think more people would probably have malpractice insurance and they would err on that side. I certainly would like to go back and check with my folks, but I think that's the reason not at the moment.
Well, to that point, Scott, correct me if I'm wrong, but if I'm employed by a hospital system and they self-insure all that risk management, I'm not a policy holder.
Right.
If I then leave their employ,
Right.
I got to go get medical malpractice insurance.
Right.
That would be. Yes, sir, Delegate.
Steve, I would feel more comfortable on line 18, we amended it to take out that last sentence. That we're just silent on the malpractice or liability provisions.
I think that's fine.
Because I think that would leave the default presumption that they're going to have some type of protections. So, Mr. Chairman, I would move to amend on line 18, strike after care period, the rest of line 18 through 20.
All right. Okay.
Second?
Been moved and seconded for the Delegate O'Rourke is to strike on line 18, starting with the word a person, and strike through the rest of line 20. Do we understand that?
I do have a question. Thank you, Mr. Chairman. So I just want to make sure that what we're doing, does that mean that if they don't have malpractice insurance, that they no longer have to notify the patient?
Correct. Yeah. You have no obligation today, whether you have it or not, to notify the patient. All right.
Mr. Chairman, I think to that point, I don't think, as Scott said, I don't think, just to reemphasize, I don't think that requirement's there for any other license, right?
It is for nurse practitioners.
Okay, for nurse practitioners.
It's been moved and seconded that it be amended to acknowledge Delegate O'Rourke's amendments. All in favor of that? Aye. Any opposed? Okay. Anyone else in the audience to speak in favor of House Bill 2457? I'll get to you, Delegate Wilson. Anyone in the audience to speak in opposition to House Bill 2457? If not, it's with the committee. Yes, sir, Delegate Wilson.
Yes, Mr. Chairman, I'd like to ready for a motion and ready to report the bill as amended.
All right,
By
sir.
substitute, I apologize.
All right, everybody understands? It's been probably moved and seconded that House Bill 2457 as substituted and further amended be reported to full committee. All right, everybody understand? Vote on your electronic or rather. And the motion to report passes on an 8-0 vote.
Mr. Chairman, thank you. I'm sorry I can't stay and
You're
stay
good.
with you longer.
And Doug, you do not need to be at full committee next week. We'll take care of that. Doug, if it goes south, I will certainly find you.
Okay.
I don't anticipate.
Thank you. Thank you all.
Doug and Kilgore, you're next. You've been very patient.
Oh, no problem.
We've taken care of the two easiest bills before us this
Oh my
evening,
gosh.
just in case y'all need. Draw the committee's attention to House Bill 1970.
Chris, hey, we done? Yeah.
Say, Mr. Chairman, it's good to be here. I haven't been in this committee ever, I don't think, in 26 years. I mean, in this committee.
Stay with us. Stay with us. Folks. Hang with us. Anyone like us? Does everybody have a copy of the subcommittee? All right. Second, does everybody have a copy of the substitute in front of them? There you go. All right. Everybody understand it? Without objection, this substitute to House Bill 1970 is properly before us. All right, fine. Now, please tell us why we need the bill and what it does, sir.
Well, Mr. Chairman, thank you. This House Bill 1970 deals with telemedicine. As the chairman knows, medicine is sometimes, it's hard to deliver in rural Virginia, and telemedicine is one way that we're able to get access to a lot of our specialty. A lot of some folks do not have to drive and leave their families and things of that nature. So what this bill does is it asks that the DMAS to submit a plan to the U.S. To get approval to cover in number 26 to cover medical for DMAS to cover medically necessary healthcare services provided through through telemedicine services. And then on page 11, it also under coverage for telemedicine services also it includes and adds remote patient monitoring services, which is very important. If you have folks that you're monitoring, you use telecommunications technology or telecommunications technology out there that can monitoring their data such as weight, blood pressure, pulse, etc. And that's just good for the patient's health, and that's what this bill does. It basically allows this remote patient monitoring services, and as the DMAS asks for this to be covered as part of their services. This is going to allow some Virginians access to quality health care that they don't have today, and I hope that you'll find that this bill is reportable or recommended reportable.
Mr. Chairman, I don't have a question of the delegate, but just a comment. There are some hospitals currently, at least on the peninsula, using robots.
Yeah.
To a great extent. Johns Hopkins uses them to a great extent. I think it's a great idea. That's really what the deal. Thank you.
All right, sir. Everybody understand what the substitute does?
This committee, we passed out a bill to do dental work in telemedicine earlier this week.
What?
So this is even broader.
Not so fast.
Don't say that. I don't want to make Dr. Pillion upset.
He's just a dentist.
He doesn't take Medicaid papers.
Oh, but I do. But I do.
Please. I don't want to be here all night long. I know you all don't want to be here, and I want everybody to get a full and fair hearing for the bills.
Huh?
So, all right, does everybody understand? Anyone have any other questions of the patron? All right. Does anyone in the audience speak in favor of House Bill 1970 as it has been substituted?
Mr. Chairman, Scott Johnson again. I want to thank Delegate Kilgore for working with us because the original bill had some heartburn that this does not, and we ask you to support it.
All right, sir, thank you very much. Yes, ma'am.
Mr. Chairman, Julie Dine with the Hospital and Healthcare Association, and we we very much appreciate you all working with the chairman, or the other chairman, working with us. We appreciate it.
Mr. Chairman, members of the committee, Robert Farrar from America's Health Insurance Plans, and we fully support the bill as well.
All right, anyone else? Anyone else? Anyone in the audience to speak in opposition to House Bill 1970? All right, if not.
Mr. Chairman.
All right, it's been probably moved to second that House Bill 1970 as substituted be reported. Everybody ready to vote? You'll vote on your electronic voting record.
This was the quickest one to go check.
And
Unfortunately, it's not quick. Am I still trying to?
Nope, I stopped that fine. It's okay.
I'm trying to, Mr. Chairman.
Are you a yay, nay?
I'm a yay. I just won't.
That's fine. The measure to report with the substitute passes on a 9 to 10.
10, Mr. Chairman. I can't get mine to work.
Sorry, you're a yay?
Thank you.
Yes, sir. And Delegate Kilgore, you do not need to be at our full committee service. Go south. Yes, sir. All right. Thomas, Delegate Thomas, you're next on our list, sir. Draw the committee's attention to House Bill 2169. 2169.
Mr. Chairman, I have a line amendment.
There's one amendment on line 24 after Romanet 2, strike, is a graduate of an approved physician assistant education program, and insert holds current certification from the National Commission on Certification of Physician Assistants.
Everybody understand it? All right. Thank you, sir. Without objection, the amendment to House Bill 2169 is properly reported. Delegates, please tell us why we need your bill and what your bill does.
Okay, very quickly, Mr. Chairman. We know Virginia's home to a lot of active duty service members. One of the things we sometimes forget is they're sometimes with us 1 year, sometimes 3 years, usually no more than 3 years, but they have spouses that are trying to maintain careers, sometimes throughout a 20 or 30-year career for their active duty service member. So one of the things that we're trying to do is take advantage of the talent of those spouses when they're with us. So House Bill 2169 would authorize the Board of Medicine to issue a license by endorsement. One of the reasons we had the amendment was there's 3 criteria that you must meet. One is you're obviously a spouse of an active duty service member. 2, as originally drafted, you only had to graduate from a course. There was a lot of concern that we should probably prove that you not only completed the course, but you were certified, so that you hold that national certification. And then number 3 is that you hold a license that's either valid or could be reinstated in another state. So it's kind of like a reciprocity, and that's the bill.
All right. Yes, sir, Delegate.
Thank you, Mr. Chairman. This is already currently done, I believe, with some other healthcare professions or similar. Isn't that correct? I think in pharmacy it's very similar. And physicians too. So.
Julie, do you have an answer?
I think it's also done for nurses as well.
It's also done, so multiple health professions.
And we did it for school teachers last year, something similar.
All right. Any other questions for Hazel? But not really. Anyone in the audience to speak in House Bill of 2169? And in the audience to speak in opposition? The medical side, you guys are good? Yep. Anyone to speak in opposition to House Bill 2169?
Second.
All right. It's probably moved to say that House Bill 2169 as amended be reported. The members of vote on electronic record.
I'm out.
Mine jumped to you.
You're The measured report passes on a 10-0 vote. Delegate, you do not need to be at full committee. If you go south, I'll find you.
Appreciate it.
Delegate Toscano, sir.
I think,
well, no, we're not quite ready for you, so.
Okay.
All right.
Is that good?
You wanted to jump front, so we're going to let you jump front. Sir.
Oh my God, I don't want to cut everybody's line. But this is the area.
As he sits down.
Excuse me.
Have another one.
I have House Bill 2750. There's a substitute which makes the bill a lot smaller. smaller and a lot more palatable and consumable by this committee. It tastes better and costs less. So, can I, whenever you want.
Let me just let everybody take a gander at it. Everybody have the substitute properly before then? Sure. Do we have an objection without objection by general consensus, the substitute to House Bill 2750 properly before us? Doug, if you would tell us why we need your bill and what your bill does.
Sure. Price transparency and provision of medical services is really, really important. The original bill was very far-reaching in that it would require anybody licensed by the Board of Health to provide an estimate to a patient of the cost of their medical service in advance. It applied to nursing homes, hospitals, etc. The substitute changes that, and it takes nursing homes out. It only applies to hospitals. Moreover, the requirement has been reduced not to providing everybody with a notice of how much they would have to pay, but providing notice to every patient that they can ask for the amount that they might have to pay for the service. So it became a bill that's much smaller than the originally contemplated bill, but it does interject a little more transparency because now patients will be told that they have the right to ask for those estimates in advance of the service being provided. That's it.
Members have any questions? So, Delia Toscano, help me understand. If you're going to require that the hospitals provide written information about the patient's ability to request an estimate, who is it that you intend the patients would have the ability to request from?
Somebody in the hospital, and the notice has to say who you will request it from.
So if it says on the notice they can go to the billing office or to whomever and so forth, how is that different from requiring the hospital to actually provide that information?
Well, because if you don't ask for it, you don't get it.
Okay.
And under the old bill, you would have to get it anyway.
Sure.
This is
An
sort of an opt-in. Right.
All right. All right. Anyone in the audience to speak in favor of House Bill 2750? Yes, sir.
Yes, Mr. Chairman, members of the subcommittee, I'm Brent Rawlings, Virginia Hospital and Healthcare Association. We worked with Delegate Toscano on this legislation. He came to us requesting some changes. We had some concerns with the introduced bill, worked through it with him. As you may recall, this initial legislation, 137.05, passed in the 2017 General Assembly. We worked carefully on that to get it in good posture. One of the things that we learned over the past year in response to another bill that was filed in the Senate and it went to study with the Department of Health Professions and the Department of Health, it became apparent in reviewing that study that there was potentially a lack of awareness among patients that they had the ability to request this estimate under law. So we felt that this was a good solution to try to move transparency forward.
And Brent, your understanding is what they're going to have the ability to request is an estimate of your charges. Are they going to have the ability to request, a radiology group that's not your employee, that's sort of under the same umbrella, or a pathology group that may not be your employee? Are you all going to be providing that, or your intent is, or your understanding of the intent is you would direct them to the pathology folks to ask their questions, or direct them to the radiology folks?
In response to your question, Mr. Chairman, this legislation or this change to the law does not change that at all. Basically, we would be providing them an estimate of the billed amount. And so if, for example, you had an elective procedure for a surgical procedure that required pathological testing, lab tests to be done, presumably that would be included in the estimate along with that of the billed amount. So, I can't answer the question completely, but this doesn't change the practice of providing patients with estimates that we have in place today.
All right. Yeah, I just want to make sure we're all clear as to what the requirements are now going to be on you guys.
Yes.
Thank you. All right. Anyone else to speak in favor of House Bill 2750? Yes, ma'am.
Mr. Chairman, and members of the subcommittee, Jill Hankin from the Virginia Poverty Law Center. I think the world's changing and patients need to know more about the cost of their care before they get it. And I think this bill is a small step in the right direction, so thank you for moving forward.
All right, thank you very much. Anyone else? Someone in the back? Andy? Nope. Anyone in the audience to speak in opposition to House Bill 2750? No? All right. Everybody understand what the bill does? Properly moved and seconded that House Bill 2750 as substituted be reported. All right. Members of vote on election. Elliot Sickles.
Oh, I'm voting aye.
All right, the measure to report passes on a 10-0 vote. Delegate Toscano, you do not need to be, you're not on it. You do not need to be a full committee.
Thank you.
You're most welcome.
Thank you, guys. I'm sorry to,
Delegate Plum, you are our sign-in lister.
Thank you very much, sir.
Draw the committee's attention to House Bill 2158.
Mr. Chairman, following the usual format, I want to say that the problem we're trying to deal with here is related to our opioid current crisis.
Do we have an amendment?
We have a substitute.
All right. We can get that, of course.
Thank you. On the one hand, Mr. Chairman, members of the committee, are you going to adopt the substitute? Please adopt the substitute.
Yep. Let me see you get in front of everybody. All right, does everybody have this substitute from, can you have a copy?
There's one more here.
Does everybody have the substitute before them? Yeah, without objection by general consensus, this is substitute is properly before us. Substitute to House Bill 2158. Delegate, if you would tell us why we need your bill and what your bill does, please.
We need this bill, Mr. Chairman, members of the committee, because of the opioid heroin crisis that we have in the state. We all are aware of that problem, and I'm not going to expand on that, but I do want to say the good news is that there's a response on the part of state government and a response on the part of private individuals to overcome some of the deaths that are related to the opioid crisis through the administration of naloxone primarily. And what this bill attempts to do is to expand the list of persons who can dispense naloxone. And Mr. Chairman, I know you have a busy agenda, but I have a constituent who brought this issue to my attention, who's done a fabulous job of establishing a private foundation as a result of the death of her younger brother that's doing amazing work in Northern Virginia. And I would like, if you could, to give her a few minutes to explain it.
Yes, sir. Someone here at the Atwood Center? Yep.
Yeah. My name is Ginny Atwood-Lovett. I'm the executive director of the Chris Atwood Foundation, which, as Delegate Plum mentioned, we started in memory of my brother. And in his memory, we dispense naloxone into the community. And we have 162 reports of lives saved in Virginia as a result of our trainings. We're trying to expand those trainings, but the further we try to expand and the harder we try to reach people who are in active use and the most vulnerable populations, the more problems we run into with the current way that naloxone is rolled out in Virginia. And what we would like to do with this legislation is to expand the list of people who can dispense, also to remove some of the other barriers that are not in place in other states, in our neighboring states of Maryland and North Carolina. For instance, they do not require a controlled substances registration. Federally, naloxone is not considered a controlled substance, and no other state in the country requires a controlled substances registration for the dispensing of it. So it's a very unnecessary and actually very unusual measure to put in place. So we would like to have that removed. Also removes some of the burden of the lengthy training requirements. For instance, when we go out to a tent community and we're trying to give naloxone to somebody who is actively using heroin, we can't make them sit for an hour-long training on how to recognize and reverse an overdose. So we have removed the training requirements for that and allowed us to operate under the direction of a physician's standing order. So that physician would oversee the program and ensure that we're doing training. So training is part of the current legislation, but not in its previously very lengthy and burdensome format. And this will allow us to get naloxone out to a lot more people, especially through methods like EMT leave-behind programs, other fast-paced settings like hospital emergency departments are currently not able to dispense naloxone because they can't spend the time that it currently takes to legally dispense to them.
And this allows a lot more of those critical intersections like hospitals, EMTs, and jails to dispense it, which are places where pretty much everybody with an opioid addiction ends up at some point, and it just increases the access for people who need it most. And that's really the heart of this bill, is to get it to the people who need it most.
All right. And Mr. Chairman, I might say that the reason we have a substitute is because we have worked with the agencies involved in the state program, which is extensive, to make sure that we accommodate the needs on the part of the state regulators as well. So I hope that they are now in agreement that the bill is acceptable going forward.
All right. Anyone have any questions?
I just had a question. So I completely understand the work that that the organization, Mr. Chairman, is describing. But in the legislation, it just says received instruction.
What line are you?
I'm sorry, on line 255. So is that instruction, and I'm sorry, I'm just getting the substitute, is that instruction defined anywhere else? Just so we know that there are some standards?
Good question, because received instruction could be, yeah, just give it quick. That's the instruction, give it quick.
If I may, this is applying to intranasal and auto-injector naloxone, which has extensive instructions on this, as well as videos provided by the pharmaceutical companies. So the training is already part of the product in many ways, but also pharmacies right now are giving both of these types of medications out very frequently and not providing any training along with it other than a brochure. So it's really not uncommon for it to roll out that way.
So I had a whole textbook of anatomy, and just because I had it and it instructed me, unless I read it and had a test on it, a lot of people wouldn't necessarily have read it. So the fact that that information is distributed with it in and of itself doesn't prove that the folks are knowledgeable and competent and capable of delivering it. So I understand. I think I understand your question.
I think that was an interesting question. I don't know if council has a tie back to it. It seems to me that would be where you would insert a reference back to a particular code section that may define what instruction is, but we don't have that.
And I think the concern is, and the bill at first was, as it first came out, this is a little bit better, but as it first came out, effectively would allow anybody could effectively become a naloxone distributor or be able to administer naloxone. It gave free range for others to now be able to grant that opportunity. Yep, Board of Pharmacy.
Mr. Chairman, Caroline Turner, Executive Director of the Board of Pharmacy. Just wanted to mention that we have worked with the Virginia Department of Health as well as the Department of Behavioral Health and Developmental Services, along with the patron and his constituent, and we are comfortable with the language. We feel that the intent is for instruction with respect to the administration of the product. Often these FDA-approved products have inserts within the package information, as you're probably very familiar with, that have pictorial directions for how to use, and that could be provided. It certainly could be an oral form of instruction as to how to properly administer it as well. But letting you know that we do not have an official position on the bill, but we are, as several state agencies, comfortable in consensus with this language.
Well, again, is that me going off? Again, Caroline, whenever every drug prescription's got a long, huge, nobody reads all that stuff, and it's simply having pictorials, and I get it for those that are educated individuals who wish to get educated, but we don't have necessarily a requirement that they truly demonstrate that they can safely and competently diagnose the issue and then administer it.
And Mr. Chairman, if I could add, there wasn't a notification from the Food and Drug Administration just last week. They've essentially sent signals greenlighting the status for an over-the-counter version of naloxone if the manufacturers were to submit application to take it over the counter. So FDA is sending the signal that this is a safe and effective product that can be sold over the counter, but we just technically don't have a version that's available over the counter. It's still a prescription-only Schedule 6 product.
All right, Doug.
Just very brief, over the patron and maybe health lifeline. Since instruction is not defined, as Billy Price pointed out, under this bill, if you administer naloxone, and somebody goes wrong, are you immune from any liability in that administration?
Yes, the law, the way it's currently written, nothing has been changed with the liability piece and the way that it's currently written provides for immunity from civil liability for anybody who's prescribing, administering, or dispensing.
All right. And if I may follow up on the package insert in the instructions, as you mentioned, there is a very long list with each one, and that's meant for the healthcare providers. But it's, what I've seen with all of them, there is a patient insert with instructions, that's pictures and so forth as well. They
All right.
always have that.
All right. Anyone in the audience to speak in favor of House Bill 2158? Yes, ma'am, if you would come forward, or you can speak from there, if you can speak loudly.
Yes, sir. Thank you for allowing me to speak. My name is Mary Crozier, and I'm the chair of Community Coalitions of Virginia. We represent 37 on the street community coalitions all around the state for substance abuse prevention, as well as other organizations and boards, and we would be in full support of this for all the reasons previously said.
All right, thank you, ma'am. Anyone else in support of House Bill 2158? Anyone in the audience in opposition to House Bill 2158? Good? You guys good? Yep. All right. Everybody understands what the bill does? So it's one last question, Caroline. So going forward, if this passes, who in Virginia is allowed to obtain naloxone and distribute it or deliver it in the Commonwealth of Virginia, other than in a hospital setting?
So the changes to this bill, you would pick up law enforcement, firefighters, healthcare providers in emergency departments, and EMS personnel. And that was with the intent that you would authorize a leave-behind dose. So if they are treating a patient, for instance, but there's high risk that this individual may overdose, they want the ability to do a leave-behind, which I think is a very custom procedure in other states. Technically, we do not have that allowance. So that would be the new additions to the existing authorities that are already in law.
Thank you very much. So, yeah, because I was going to say, because that what Caroline just said is not what we have before us. So
There are some additional amendments. Yeah. Yes. Are there additional amendments to the substitute that may have been made since I received
to bring in law
substitute
enforcement
language?
The patron is unaware of it.
So is the chairman.
Our apologies. We thought word had gotten to the patron. Yes, there was additional meetings with the constituent with the 3 agencies, and yes, there are a few amendments that have been emailed, I believe, to Ms. Andrews. There are. Thank you very much.
Thank you very much.
So, I do not have copies. This has happened while we were in the meeting. So there are no copies of these, but it appears from what I can tell looking at what I received, there are a couple additions to the substitute language that, 236-ish. We will also add law enforcement and firefighters to the list of individuals who may dispense. And then I believe there is one additional line amendment in subsection Y. At the end of the new language about line 262, at the end of that new language, that would require DBHDS to ensure implementation of training by July 1, 2019. And that would be training related to, I believe that's the administration using hypodermic syringe.
Yeah, no, I understand that. So, Delegate Hodges.
I do have one question. This allows the dispensing of it, but what about the purchase of it on the back end to allow all of these providers to purchase and firefighters and so forth to acquire the product? To purchase the product and so forth, so, you know, they can dispense it. So there's a difference between dispensing and purchasing the product on the back end. So how would they be able to obtain the product?
I think the paragraph already covers that, but I would be glad to look over that and see if there's a need for additional inserts. But we were working off of the already existing language, which I think.
I think that's probably covered up.
Okay. All right. All right. So let's bring this back here, Delegate Hodges. All right. I don't work off concepts because Chairman doesn't want like concepts. We got to work on bills that have words. So what I would suggest we do is consider the substitute that's before us. Delegate, if you want to try to get one of these ladies here this evening and try to corral them maybe after near, we could take it up later if you want to say goodbye temporarily to do that, or we can address the substitute as you've introduced it, and then have a conversation with pharmacy folks and healthcare communities and public safety folks and so forth, and offer that amendment to the full committee next Tuesday.
Mr. Chairman, if you don't object, I would like you to do that. If we could just deal with that as you presented and add that language. And I apologize, I really thought that was part of it.
Not a problem, that's just one more whipping I'll get from Delegate Orlock for not having it done properly, but, all right, members, so we have before us, substitute to House Bill 2158, and they're gonna, the intent is that they'll work on some more language to try to bring in the firefighters and the law enforcement, and perhaps Delegate Hayes had just raised an issue about perhaps the jailers and law, DOC folks, and they're not encompassed under, there may be a lot more folks between now and Tuesday that are gonna come to your door and try to, Christmas tree onto this, and Delegate Orlock is a very compassionate and caring guy with a lot of patience, but his patience is not unlimited, and we do have to have this done by next Tuesday. All right. You'll have it ready. Okay, good. Members, do you understand what's before us? I think what you want to do is actually move it out so it's the day.
No. I withdraw.
We can take it by the day, but I suspect probably what we want Delegate Sickles is to move this substitute, and then if the substitute's not amended before Tuesday, perhaps we would take issue with it. If it is properly amended, I think Delegate Orlock would probably, Chairman Orlock would probably consider that amendment. Can't speak for him.
Second.
Right, so it's been probably moved and seconded that House Bill 2158 as substituted be reported. Everybody understand? All right, members to vote on electronic voting questions. All right, the motion to report with the substitute that passes on a 10-0 vote. I would recommend you be there next Tuesday. Maybe have a conversation with the chairman between now and then.
Thank you so much.
Yes, sir. Thank you. All right, we've taken care of the 4 easiest bills so far this evening.
But I would like to know your thoughts on it.
For about 30 seconds.
I could try to get more.
Delegate Tran, you are next. Draw the committee's attention to 2493.
Hello. Thank you, Tom.
Do you have a substitute amendment? Everybody else did.
No.
Members,
No
you
more.
have. All right. Committee members, you have before you House Bill 2493. Delegate, if you would tell us why we need your bill and what your bill does. Please.
Sure. So in 2016, Senate Bill 712 amended the Code of Virginia to allow dental hygienists. I'm the daughter of a dentist, I can't pronounce the word properly, but to practice through remote supervision. And what that bill did, though, was there were some unintended omissions in 2016 that we want to rectify this round. So this bill allows for dental hygienists to administer Schedule 6 drugs that have been prescribed by the dentist while they're working with patients, and it also lifts the age cap on the application of fluoride varnishes. So currently, dental hygienists under regular supervision are allowed to apply the Schedule 6 drugs as prescribed by dentists. And so we want to make sure that the remotely supervised dental hygienists have the same opportunity to perform these tasks. So I just want to be clear, a remotely supervised dental hygienist is somebody who is providing services or rendering services to a patient while the licensed dentist is on site, but either working with another patient or taking care of a different task. So it's different than some of the remote and telemedicine that we were talking about earlier.
And Doug, just make sure, I don't want to make sure I misunderstood you, but I don't believe they currently have the authority to prescribe Schedule 6. They have the authority to be able to apply topical antibiotics for certain conditions under the, is that correct?
Absolutely, and we're not changing that.
Okay.
And then for fluoride varnishes, it's currently you can apply fluoride varnishes from the ages of 6 months to 3 years, and so there's actually just good practice to apply them to children who are older age and sometimes even adults and such, and so we would just lift those age restrictions.
All right. Members have any questions, patrons? Okay. Anyone in the audience to speak in favor of House Bill 2493 that has no amendments or substitutes?
So, David Brown, Director of the Department of Health Professions, which has supported dentistry. This is a board of dentistry bill, it's an agency bill, the administration supports it, and it does really help fully implement the value of dental hygienists being able to be remotely supervised.
All right, sir, thank you very much. Anyone else in speaking? Yes, ma'am, please come forward.
My name is Susan Farr. I'm a dental hygienist and licensed in Virginia, and I serve on the executive board of the Virginia Dental Hygienists Association. We are happy to thank Delegate Tran and the Board of Dentistry, the administration, and the Virginia Dental Association for working with us on identifying and proposing the fixes to the restrictions and omissions that were never intended in the code in 2016 and that inadvertently prevented dental hygienists like myself from serving all of our patients and administering the Schedule 6 drugs that our patients often need, whether we're practicing under remote supervision, indirect, or general supervision. So it accomplishes two things. It allows us to administer these board-approved Schedule 6 drugs under the remote supervision of a dentist who prescribes the drugs, as Delegate Tran said, as opposed to just being allowed to apply these under indirect or general supervision. These topical drugs include topical anesthetics, topical antibiotics, and the topical fluorides, such as the fluoride varnish. The bill also allows us to administer topical fluoride varnish to patients of all ages, as opposed to being restricted to applying the fluoride varnish on children under the age of 3. So I know of a hygienist in Northern Virginia who is working with children, a group of children under the age of 5 or 5 and under, and under this law, she is only allowed to administer the fluoride varnish to children under the age of 3, half of whom don't even have teeth yet. So the VDHA strongly supports this legislation, and we urge you to report this bill. Thank you.
Thank you very much. Anyone else in the audience to speak in favor of Delegate's bill? 2493. Anyone in the audience to speak in opposition? So we do have a pediatric dentist in the room, Delegate Pillion.
Care for all. Care for all. This is a good thing.
I'll seriously. So not a problem with dental hygienists applying all these topical
Absolutely
agents,
not.
antibiotics, and so forth. All right, sir. Thank you very much.
Thanks.
Thank you very much. Just a second. All right, so it's probably moved and seconded. House Bill 2493.
I just got your bill passed. One sentence.
Tran, you owe me.
This daughter of a retired dentist says, thank you very much.
All right, Delegate Tran, that
Sorry,
measure,
you called him.
Delegate Tran, that measure reports on a 10-0 vote. You do not need to be at the full committee now.
Thank you.
Very much. All right, if there's anyone in the audience to hear, Delegate Guzman's House Bill 2128, that effectively, I think all the elements of that were taken up with Delegate Kilgore's bill on telemedicine. I think she's asked for it to go, I guess, be stricken from the House? Yep. Move strike. Okay. Move this, I think we need we need a recorded votes for strike. Members to vote on the electronic voting record to strike 2128. Delegate Davis, I see you here as well. House Bill 2245. House Bill 2245, draw the committee's attention to. Good evening, sir. Do you have an amendment or a substitute?
It should be yes, sir. All these bills floating around today, I do. The thing is being ready to pass around. I got one here, but I can put that one easier for you.
Move the substitute. Everybody got it properly before them? Right. Without objection and by general consensus, the substitute is House Bill 2245 is properly before us. If you would tell us what your substitute does different than the underlying, because I suspect there's some moving parts.
Just a little technical changes by the Board of
Technical.
Yes, sir. Yeah,
All right.
the Board of Pharmacy did a better job right here.
All right, sir. If you would tell us why we need your bill and then what your substitute does.
Sure, yes, sir. So last year, we all remember that we passed legislation that allows medical CBD oil to be utilized on the recommendation of a doctor. Last year was about getting the policy right. It wasn't about making the best opportunity for viable, cost-efficient businesses, or making sure that we created a model that met the demand. It was all about policy. This comes before us today to make sure that those that we deemed want to make it available for, in many cases, the elderly, those with severe disabilities, have access to this product upon the recommendation of their doctors. What this does is last year we broke the state into 5 geographic territories, and some pretty large territories, and only issued 1 vertically integrated license, which meant you had to grow it, process it, and also retail it from that location. You could not take it off site. Additionally, that first meeting with the patient had to be there, and in many cases, that patient would have to drive hours away. Additionally, you could do deliveries to your patients after that, but we can imagine the cost for a distributor to be driving hours to deliver to the patients, and we've seen in Pennsylvania what this has done to the cost of these products to the people that need them most, and in many cases, as we know, it's not covered by insurance. What this does is goes to 10 licensees, not just 5, which allows us to increase the supply, and I'll speak to why we need to increase the supply in a minute, but it goes to 10 licensees, 2 per each of the 5 geographic territories. Additionally, to help out with the transit piece, we allow the Board of Pharmacy to license 2 additional distribution centers, so that these facilities can actually have distribution centers in areas so we don't have to worry about the long transit time. Basically, Mr. Chairman, last year we passed a bill and told Virginians that we were going to ensure with this bill that all Virginians had access to CBD oil when recommended by their doctors for some of the most severe diseases or in replacement of opioids. This bill helps deliver on that promise.
All right, sir. Members have any? Yes, sir. Delegate Bell.
Sure. Delegate Davis, are any of the 5 originals operational now? Are they up and running?
No, sir. The original 5 are not operational, and furthermore, the additional licenses would be chosen from the applicants that had already pre-submitted.
Yes, sir. Delegate Bell.
It seems to me that we're getting a little ahead of ourselves here, that we ought to give this model a chance to work and see if it's going to work. That's kind of where I am. Doubling the number of facilities before we ever get one operational, it concerns me.
Mr. And Delegate, I would say I completely understand, but I can assure you with 99.99% certainty that this model will fail that we have today. And the reason I can say that is if you look at other states, Maryland, for example, had 130 licenses for a population of 6 million people. Massachusetts has 38 licenses for 6.86 million people. Pennsylvania, 150 for 12.8 million people. In Virginia, we have 8.4 million people and 5 licenses. We already know, all the numbers show, supply will not be there. Transit times are going to be a detriment to those that need it most. I would agree to let this stand up, except we know that we approved good policy last year, but we didn't focus on a good business model. Additionally, I would say that if these people stood up their businesses now based upon large transit situations where they have to deliver stuff, and then in next year or 2 years, we pivot to this, they're going to have to recreate that business model, allowing for the distribution centers. And as we all know, there's a cost when you pivot a business model, that cost gets passed on to the consumers.
So, Delegate, I was happier with where we were last year. Now I'm hearing you say that we're going to have this available to elderly and severely disabled and to 8.5 million Virginians at the physician just simply has to prescribe it. That actually creates more heartburn for me. I get it. I'm at peace with the reality, in my opinion, that CBD oil has utility for seizure disorders, chronic nausea, pain, so forth with cancer folks. I actually am at peace with that. Not so sure we want to have it readily available to any elderly person.
I think I misspoke. I apologize, Mr. Chairman, and not coming from the medical field. It doesn't change who can get it. If a doctor has a recommendation that gives an affirmative defense for someone because the person has cancer and they think this is best treatment. Those that are younger, those with relatives, have a better chance of driving the long hours to get that prescription or get the product than an elderly person would by themselves afflicted with the same disease. So we don't expand the scope at all, Mr. Chairman. We just make sure that those that you've already deemed appropriate to have access actually really has access.
All right, Delegate Keys.
Just a brief question, and it may not even be part of this legislation, but it's related, and I think goes to a lot of the concerns that some people may still have with this whole subject. Are we talking about anything regarding any hallucinogenic components
No, sir.
to any of this?
No, sir. All this bill does is take exactly what we allowed to be used last year and how it's allowed to be used and ensure that all Virginians truly have access to it when those requirements were met from last year.
Delegate Price.
Mr. Chairman, Delegate, when you say all Virginians, you're still talking about, so when you were listing out the numbers and you were saying Maryland and other states, you were just saying based off population numbers and associated need?
Yes, ma'am. You can compare ratios of a population size of X. There's a certain percent that have certain diseases that doctors have deemed would be helpful through CBD oil, medical use CBD oil. And given those populations, you've seen a certain number of licenses given. Even if we are significantly below par and below standard, we are still very underserving that population given the only 5 licensees that we have out there today, which may not hurt the youth or those with large families, but the elderly and severely disabled with some of these diseases are going to be the most impacted by inability to be able to get the product.
All right, Delegate Hodges and then Delegate Sickles.
Thank you, Mr. Chairman. And during the application process, I believe before was what, $10,000
Yes, sir.
non-refundable application to the Board of Pharmacy, which at that time was a blinded scoring process.
Yes, sir.
So my question here is, if you reopen that process, is it still blinded because, or, we know who those applicants were, so it's no longer a blinded scoring process. Is that correct?
So here's the process working with the Department of Pharmacy and what they've requested. It is since everyone's already submitted an application, there is a nominal fee. It's $1,000 to have your application reconsidered. There's an additional, there's $1,000 fee if you'd like to make changes or resubmit that application to address maybe some shortcomings in prior applications. Those fees will actually allow the Board of Pharmacy to bring in professionals to help grade these applications. One thing we heard in the past was some of the grades dealt with things that maybe members in the Board of Pharmacy may not have had an expertise or experience in marketing, etc. This would allow them to be able to come on board.
So follow-up question.
Yes, sir.
Thank you. So follow-up question, this would be a different scoring process than what was used initially
Yes,
for
sir.
these follow-up applicants. Which
Much more fair, yes, sir.
Well, not more fair, but a different process than
Yes.
what they used before, and then they would know who these applicants are, which could then open up the lobbyists and attorneys and everyone else going in, which did not occur in the initial process. Is that correct?
I wouldn't say it did not
I don't mean that in a
occur.
bad term, but it would open up the process, it would open up the process at the board to have folks coming in at that point, which did not occur in the initial process. And then one follow-up question, Mr. Chairman.
Delegate Hodge.
Shortage of pharmacists, pharmacy technicians, botanists, chemists, so forth. I mean, it's hard to fill that void now in the Commonwealth. Expanding that, I couldn't see it actually working in this marketplace. So, I mean, where would those people come from?
Well, I mean, so Mr. Chairman, I would say that this is a new industry, a very lucrative industry. If you look at building posts, they had not seen them in other states. You look at in Maryland, just to the north of us, and what was that, 130 licensees there, and they have to have certified members that will be pharmacists on board with those. There are 5. If they don't have one, then obviously they can't have one of the distribution centers. But we're talking 3 more pharmacists in certain areas. If they can't meet it, so be it. But if we don't give them the chance, we can ensure that there are Virginians that will not have access to this product, given the codes from last year.
All right, Delegate Sickles, you had a question?
Yeah. Is it true that when the 5 district, 1 for each district, was considered, that there were only about 5,000 eligible people per district that might have an indication for this treatment, and now, after last year maybe, we expanded the number of uses, the number of indications for using this, and that is did you say this already? Is that one of the reasons? So it was a tiny little number of people we're going to serve. now that each district is gonna serve a lot more people
Yeah,
because of
so,
what we did last year?
yes, sir. So prior to the bill last year, not only did you not have licensees, but the use was restricted to epilepsy, correct? I think maybe one of the use.
Intractable seizures.
Yes, sir. And now we've with that bill last year that granted licenses also opened up the doctor's right to choose, and that opened up the number of people that would be seeking and qualified to utilize CBD oil per doctor's recommendation, sir.
Can I ask a second question?
Yes, sir.
Just the distribution center, the distribution points is interesting for me from Northern Virginia because I think our licensee, who is somebody that I know amazingly, is going to be growing the product a long way from the core area, and I could see how having to distribute it from there, if they had to distribute it from there, or customers had to go there, both of those are problems.
And both of them are going to be a requirement. The first one has to be in person on site, so that person, regardless of age or disability, is going to have to drive X number of hours to see that facility and get their first use.
Yeah.
And then in the future, they either drive, or like you said, someone's going to drive out there, and that cost is going someplace, not covered by insurance.
All right, Dr. Price, you have a question?
Yeah, I just had a question. What was it an administrative cost or decision in order for it to not be opened back up? I understand the $1,000 for the previous applications, but if we chose the 5 best out of that round, why wouldn't it be a new process since we're adding on to it?
The thought was, one, for expediency, and secondarily, we have a very good pool of applicants. And the thought was to, and because of some of the concerns over some of the analysis of the entire pool, to let them look back at that pool where there are some great applicants that we're not being able to give them an award because of the limited number of licenses. And additionally, to look back at the applications would be such a smaller cost. Because they're already known, the applications are already known to the board and the decision makers, and at most it's going to be some small changes to the application.
Yeah, I just.
Okay, Delegate Peach, you have a question, sir?
Maybe 2 comments.
Yes,
At appropriate time. Okay. To Delegate Sickles' points, I mean, the Joint Commission on Healthcare approved the policy recommendation that now Congressman Ben Klein put in last year that led to the point where we are now. What surprised me, last year when all of this started rolling out, I felt like we had just ended session. And then it was already happening and people were already getting these approvals. And to be honest with you, it kind of felt like it was the inside job. I'm not trying to, cast aspersions, but it was rapid fire. And I know I was contacted by a number of people who said, hey, I'm pretty interested in this. How do I do this? Where do I go? Put my business model together. In prior life when I worked with Smithfield Foods, we always heard from the Justice Department about the dangers of vertical integration. Here we are, we're sponsored. I can appreciate it from a security standpoint, et cetera. But I personally don't see a problem with opening it up to a new pool of applicants. We've gone down that road.
If there's a desire to open up the applicant scenario, I think we can work at that from an amendment standpoint. The thought was for expediency and from known basis, we've got a really good pool to pull from, but I think that it would be the preference of this committee on that point.
All right. Anyone in the audience to speak in favor of House Bill 2245 as substituted? Yes, ma'am. One forward.
My name is Cassie Schroff from Wirewoods Consulting on behalf of New Age Care. And Delegate Sickles alluded to the very fact that 3 years ago when this program was created, it was really created to help about 27,000 patients with intractable epilepsy. Last year, the legislation really gave doctors the choice to decide what conditions were appropriate for treatment, but we didn't increase the number of licenses. 5 licenses was decided for about 27,000. Now, no matter how way you slice it, that population is going to get bigger. So we support the legislation by adding the additional 5 licenses to really meet the demands of Virginia's patient population, and we hope that you'll support the bill.
All right, thank you very much. Anyone else in support? Anyone in the audience in opposition to House Bill 2245? Yes, ma'am.
Hi. Good evening. I'm Farzana Kennedy, president of the Virginia Medical Cannabis Coalition, which just came together of the 5 licensees that were awarded the licenses recently. I speak in opposition to this bill for the request for more processors. With support of the Board of Pharmacy, we feel we are in a good position to meet the needs of the Commonwealth. We still need to determine the size and scope of the patient population. We have not opened our doors yet, and would like to before we look to do expansion. We are also concerned about opening the hemp CBD to the patient population, not subject to the same regulations as the processors. We're asking to hold off on passage of this bill till we are open and have more data. We believe that at this point, looking at the patient registration and physician's registration through the Board of Pharmacy, the data is not there to support for more processors, and we have not yet opened our doors. We're not there yet. We would like to get some data and maybe have this conversation another time.
All right, and when you applied for, you have one of these 5 licenses?
Yes, HSA2.
When you applied for that, were you given some sort of data or from the state about how many folks you thought this might apply, what sort of business model you could put into place, how many folks you thought you might be able to serve?
Yes.
Were you given some sort of,
Yes, they
is
have.
that part of this process?
Yes, they have.
Okay, that's great. Anyone else in the audience to speak in favor, speak in opposition, I suppose? Yes, ma'am, come on forward.
Yep. Hello, I'm Dr. Mary Crozier again. I'm the chair of Community Coalitions of Virginia, as I mentioned before, and we oppose this bill for a number of reasons. I really appreciate the apprehension that many of you have shown, and so many of us are just surprised that we're talking about, cannabinoids here in Virginia. And it seems to me that the use of the word product is very curious, because that's the word we used in the 60s for drugs on the street, and you're not using the word as a medicine. This is not an FDA-approved medicine. There's not official standardized protocol in the medical community for what a dose of this oil is and to whom it should go based on age, gender, weight, medical condition, history, etc. We don't have that information yet. It's similar to how we have like blood alcohol level charts. We don't have that yet with these oils. So this is very new, and I agree with some of the comments that have already been expressed that we need to wait and see how this is going to roll out. You have tasked the Board of Pharmacy with supervising this. It's a whole new thing, so I think we need to wait and make sure that we have the best protocol in place for all the citizens, and that we're not really creating more unintended consequences here in Virginia. We understand from learning theory that as availability goes up, so too does use. And I think we've kind of heard that in this conversation right here, so we're very concerned about that, with more and more processors being available in our area. So we would hope that you would oppose this, because this is illicit substance right now, and we would wait. We would want to give caution and allow the Board of Pharmacy to roll this out and see how it goes. I also want to say Francine Katzen is here. She's on our board with Sakova.
And I also oppose it. I'm a parent on the board of Sakova. Got involved because I have a daughter in long-term recovery, and her gateway drug to heroin was marijuana.
Right, and again, ladies, we're really talking about two totally different
oils.
chemicals,
I understand
two totally
that.
different drugs,
Right.
if you will.
Yeah.
Okay. Thank you all very much. Anyone else in the audience? I appreciate you coming here this evening and hanging with us. Yes, ma'am.
Yes, Ashley Allen on behalf of Dharma Pharmaceuticals. We are licensed winner for Region 3. I just wanted to clarify a couple things. The Board of Pharmacy is required annually to report on the registrations, and as of December 2018, they did a report. There are only 201 patients currently registered for the state. So we feel that it may be too soon to open this up, as the 5 of us currently have 201 patients that we would be serving. So thank you so much.
All right. Anyone else in opposition? All right. And then just for, if I may, so my only consternation, Delegate, is we put into place, in my words, a pilot program. We're gonna, I think the General Assembly developed a comfort level as there is value and utility to CBD oils, CBD oils. We put into place a process, it's beautifully orchestrated. We've got 5 distributors, those are vertically integrated, so they manufacture, create the oil, and actually distribute and produce the oil and have it available and so forth. What you're asking us to do is to create not 5, but 10 of those vertically integrated and additional 10 dispensing facilities that are in those areas. And my only concern is we get, as they said, they haven't even opened the doors. I do believe the Commonwealth made a commitment to the 5 folks there. Don't know what the arrangements were. I haven't seen any of those contractual relationships, but I do believe the Commonwealth made a commitment to the folks about some sense, as the lady said, of what sort of amount of product they would get. I just don't want to undermine their business models as we're trying to get more partners. I'll give you the last word. Anyone else have any questions of the delegate or any concerns? All right, sir. You have
Just one quick question. Registration of physicians. Do we have any idea how many physicians have expressed interest in registering?
Yes, I can answer that. It's 218 at this point registered as of December 2018.
You have the last word.
Thank you, Mr. Chairman. I can appreciate the concerns of the licensees here. I wouldn't expect anything less. If I was given a taxi medallion, I wouldn't want any more taxi medallions either. And that's kind of what we're looking at here. So I can appreciate the concerns. I can assure any of them that they will not meet the demands. They didn't create the design that they have to operate in, we did. They have to vertically integrate from one location. They are not going to be able to meet the demand. There's no business model out there that would allow them to do it, either from supply or from transport. Now, they may be able to meet it with transport. We've seen it in other states. But as we all would expect, it raises the cost of that product to the end consumer. Once again, please keep in mind that insurance companies normally don't pay for this. I do understand right now there's only 210 patients. There's a lot of confusion of industrial hemp CBD on Amazon versus what we're creating. I had to explain it to my mother the other day. And additionally, there isn't a lot of information out there around this. But the minute, and we've seen this in other states, the minute the door opens, the minute more doctors sign up for this, it's going to explode. And at that point, it's too late to meet demand. You're years away. This is Virginia looking ahead and knowing the 5 territories, the 5 companies. It was kind of an arbitrary number. Let's get the policy right. And I will end on this. And I am not a doctor, Mr. Chairman. You can correct me if I'm wrong on this, but all the research when I was working on this bill the last 2 years, the big thing that stuck with me was the experience in some of the studies that showed that in some cases, opioids can be replaced with CBD oil. And we all know about the opioid crisis and the opioid addiction crisis. And there are a lot of people dealing with this today. There are a lot of people tonight, tomorrow, next week that are going to be prescribed opioids that may have been able to be prescribed this, A, if it was available, and B, if they actually have real access to it. And I feel that that's an overwhelming reason to make sure that we have enough supply of this, because it seems like this could be a game changer for many Virginians, especially when it comes to this. We just have to make sure we meet the promise that we gave to the Virginians last year.
All right, so I'm not so sure we want to make the argument that we now want to be prescribing CBD oil instead of opioids, because that's kind of like saying we ought to be juuling instead of smoking.
I'd rather not do either, but yes, sir. Yeah.
All right. All right. I think we've, Doug, you've done a great job. You're a great advocate for your bills and for your community, and I say that sincerely, and your business concerns as well. All right, this committee works by way of a motion. I think we've heard all the issues.
I'll get them.
Second. All right, it's been moved and properly seconded that the bill be gently laid on the table. The members will vote on their electronic voting record. And the measure to lay on the table passes on a 7-3 vote.
Okay. Thank you, Mr. Chairman.
Absolutely.
Thank you, committee.
All right, next we have Delegate Pillion, and Delegate Mullen has a very comparable bill, but Delegate Pillion, I think yours bill maybe a little bit broader in scope. So, Delegate Mullen, stay in the bullpen. If there's if there's other elements to it.
So there are some notable differences, and I think we'll have some commentary during this.
Yes, sir. You may actually sort of go ahead. Okay. All right. Do you have a substitute?
I do have a minor technical friendly amendments that were suggested by DARS. And Sarah, I'm sure, has those today.
Let us get this. Hang with me, folks. Let me get this properly before.
This time they're in paper form.
you want me to talk about the minutes?
Not just a second, let me get it to you.
We'll find out.
Yeah. All right, did everybody got the substitutes before them? Everybody got the substitutes before them?
It's online as well.
Yeah, it should
It's
be online.
All right, without objection, this is properly before, so the substitute to 2560. Doug, if you would tell us what the substitute does originally, because a lot of us read your bill at right night. And
Sure. So
help us understand.
these are friendly amendments suggested by DARS, and they ensure that we include cases of neglect, and that we align the confidentiality language with the adult fatality reducing language.
All right, let's sort of get that piece. Okay. If you would tell us why we need your bill, delegate, and then what your bill.
So we know that in
will do.
Virginia, we do a great job at taking care of vulnerable populations. So child abuse, multidisciplinary teams do a great job. They're a hallmark of child abuse prevention programs. And we in rural areas especially, we see that there's an increase in elderly abuse. So in one of my counties, Wise County, we have formed a elderly abuse multidisciplinary team to deal with this. Very similar structure as a child abuse team, but for the elderly abuse that we were suffering from. The difference between this and the childhood is that this doesn't require that there's formation of specific, this bill doesn't require that our communities do it. It just provides a statutory framework to encourage, when appropriate, the creation of a team. And like I said, most localities don't have this now. I'm fortunate to have one in my community. And the reason that most localities don't have it is because there's no statute that says they can. That's the common response that they say. So, the Virginia trial lawyers decided that they needed to, their committee on elder abuse prevention met and said that they needed to endorse legislation that would allow for this creation. And here we are today.
All right. Any members have any questions?
Yeah.
Kelly, do you have a question? You're good. All right.
Talking to myself.
No, you're good. Anyone in the audience to speak in favor of this substitute to House Bill 2560? Yes, ma'am.
Hi, Senator Garrett, I'm Tracy Quackenbush Martin for the Virginia Association of
Demoted.
Slanderous.
Demotion. Tracy, tell me again, Tracy, who you're with?
Becca.
Okay.
We're here to support both this bill and the one to come from Senator Mullins. I'm sorry, Delegate. So if I can, I don't know if I need to speak anymore. I spoke with.
You're in favor of it?
Yes.
All right.
Yes.
Anyone in the audience else to speak in favor of House Bill 2560? Anyone in the audience to speak in opposition to House Bill 2560? All right. All right. Delegate Mullins, did you have something to add? Because if we pass this bill, yours, we probably.
I mean, you wouldn't pass mine. I just wanted to.
No, not that we won't pass it, but if you've got some elements or something that if you have conversations you can add to, or you're good. You're good. All right. Go ahead.
I just wanted to check with staff at this point. Has this made both of our bills identical at this point?
If we were to adopt a substitute to your bill, it would make them identical. The substance of the bills.
I'm sorry. What are the primary differences at this point? I apologize.
No, you're fine.
I'm not on the committee and I don't
So,
want to interrupt.
if you look at the two bills as introduced.
Sure.
The changes that we have in 63.2, both bills add that language. There's like a tiny bit of wording difference here and there, but the substance of them is the same. What they do, how they work. Delegate Pillion's bill also included a couple other sections that probably should be in both. The sections that allow you to have some of the protections from disclosure of records for the FOIA exemptions for meetings and records of these organizations, and then also the authority in 15.2-1627.5, alerting the attorney to the attorney for the Commonwealth that you may establish these multi-jurisdictional teams. So probably what we should have as both bills would need to be identical. Thank you.
May.
Or we could, if your elements are being embodied here, you can chief co-patron.
Yeah, I'm happy to strike my bill and just come on if
Sure.
the delegate is willing to come in as a chief co-patron. We can just use this in this vehicle. The only question that I had was that one of the things that we always try to address in courts is the fact that when you start to make specific exceptions for FOIA for something like this, you can read the code as meaning at that point that there are no other exceptions. The Commonwealth Attorneys Association has generally taken the proposition that these are already not FOIAble documents. Nobody wants to be able to make sure that any of the documents that could be considered by the MDT to be publicly accessible. We don't want that to occur. But if we now say, well, only these are specifically accepted from FOIA, does that then create the proposition that everything else is FOIA? I just wanted to make sure that that was with staff.
So I don't think that's a concern you need to have here, and I will also point out to you that in the area where we added the exceptions for these join a list that include the information reflecting the substance of in the meetings piece. Substance of meetings in which individual sexual assault cases are discussed by sexual assault response teams, individual cases involving child abuse, and so it puts these adult teams in the same position that the teams for children currently are in, so it mirrors that.
And all my concerns, I can just strike my bill, Billy Williams kind of allow me to come in and, it's a good bill, by the way.
All right, thank you. Anyone have any other questions for Billy? All right. So we have before us the substitute for House Bill 2560.
Second.
Probably moved and seconded House Bill 2560 be reported as substitute. Yep. The members of the electronic.
$4 billion.
Thank you, Mr. Chairman.
Yes, sir. And Billy, you do need to be a bit because you'll be there anyway. All right, and from the Delegate Mullins' bill is House Bill 1775. I would entertain a motion to strike it from the I'll be moved and seconded. Members will vote on the voting record.
Thank you, Mr. Chair. Appreciate it.
And Delegate Mullins on the floor. The measure to strike passes on a 10-0 vote. So I want to appreciate and thank you for working with your colleagues, sir, and I say that sincerely. You know, we have, as Governor said, as the majority of minority leaders have all said, there are things that we can all work well, and I really do appreciate this is common sense legislation.
To piggyback on that, Delegate Mullen, I appreciate you bringing the courts committee to this subject.
I can speak to the chairman about having you get on HWI.
Well, if you'd like to come on, we're going to be in courts until about 10:30 tonight, so come on over. We'll probably order things in about an hour.
Your argument, Mullen, though, was reminiscent of Madison and Henry over the inclusion of the First Amendments to the Constitution. The inclusion of this to the exclusion of that.
Yes.
So thank you so much.
Thank you all very much. I appreciate your time.
All right.
Stay out of court.
Yep. Let me just deal with no. That's good. Delegate Lean has with us House Bill 2426
and 2427.
Well, let's do one at a time. Do you have amendments or a substitute?
2426. Sarah has the substitute there, and I even have a couple small line amendments to that substitute, but they're tiny. They're literally one word changes. I probably do, because sometimes I'm not sure I have the latest version. Okay. So.
Hang just a second. Everybody have the substitute before them? All right. Without objection, by general consensus, it's properly before. So, tell us why we need House Bill 2426 as substituted.
I'm happy to. Should I put the tiny line amendments in it now or later?
No, if you've got them, we need it all.
I got them. All right. So on line 53, the first A to return a fee would be changed to the word any. Change A to any fee. So add the words NY, A-N-Y instead of A. And the second tiny line amendment is on page 54. It changes the first word or to and. Change the word or to and the amount of any copayment.
Big difference between the word and, but everybody understand what these two tiny amendments to this substitute?
I don't know what the bill does.
We're getting there, and then
Can we approve line amendments and I'll explain that?
Hang with me. Does anybody have a problem with having that copy before us? Okay. All right, as amended and the substitute for 24-26. Delegate,
Yes.
please.
Okay, so the purpose of both 24-26 and 24-27.
Let's do one at a time.
I know, but the purpose of them is to, 24-26 is a bill to let you know the cost of your drugs before they're dispensed to you. So this is a bill supported by Virginia Pharmacists Association, and what it does is it says that before dispensing a drug, what the pharmacist does is if you don't have insurance, they tell you the cost. If you do have insurance, they put it through their system, and they tell you your specific cost based on your insurance. And then if you don't want it, you don't have to get it, but they can't dispense it and then say, hey, you're surprised you owe it. That's the heart of what it does. I can get through details if you like.
Any questions? Delegate Hodges, since this affects pharmacies.
You're saying that the pharmacist has to give them cost prior to dispensing?
Yes.
Who's gonna pay for that? I mean, I haven't heard from BPHA on the bill.
Well,
on this bill, because number one, the pharmacy actually pays for that transaction. Every time something's transmitted in a transaction charge, which goes actually to a switch company, not a PBM.
So, in order to resolve that question, if a pharmacist finds out the cost and ends up dispensing the drug, they're going to pay that charge anyway.
They're going to pay what charge?
The transaction charge.
Well, okay.
They find out the
If
cost.
they dispense it.
Okay. If they don't dispense it, then this is what lines 51 through 55 do. Then the health carrier or pharmacy benefits manager returns any fee imposed on pharmacy for the purpose of turning a cost. So I try to anticipate that problem. If someone shops around and says, how much is this drug? And they say it's $123, they say, I'm not going to pay it, then they get their fee back. So there will be no cost to the pharmacy, which is why the pharmacists support this bill.
Would you do that? Because, excuse me, Mr. Chairman, there's a transaction charge each time. So it would be impossible for a pharmacy in our workflow. I mean, if patients are doing this, we want to know a price before to dispense it. Then they say they don't want it. That's two transactions right there. And that's paid to a switch company at a PBM on the back end. So it goes to a switch company, then the PBM, then reverses back. So if you process it and reverse it, that's two transactions. There's a cost to, and if they don't get it, there's a cost to dispense, which you don't get if they don't get it. Plus you're paying a switch fee. So that switch fee, the PBM's not going to pay you that back, and it's impossible to know at the end of the month when you're billed for all of these transaction charges through your software vendor. It would be impossible to reconcile that and to know that.
So, I spoke with CVS, with the pharmacist, and they said they could refund those fees. That's why it says return any fee imposed on pharmacy.
With who?
I spoke with Mike Ayat with CVS.
Well, they own a PBM.
Right.
So they would know.
And I also spoke with Juliana, the pharmacist benefits.
Hang with me.
Yeah, sure.
All right, let's hang with the, because I think his was more rhetorical than it was actually asking for. Hang with me. Let me hang with me. Because I think we can maybe be able to get some more insight from, if there's anyone else in the audience. Anyone in the audience to speak in favor of House Bill 2426? Yes, ma'am.
Yes.
Come on forward. Let us identify yourself and give us your testimony.
Yes, my name is Marisa Brown. I live in Vienna, Virginia, and I'm a registered nurse, registered in this Commonwealth of Virginia. And I'm here to speak to the importance of transparency for us as consumers. 62% of bankruptcy cases are related to the cost of medical care. The Centers for Medicare and Medicaid Services estimate the average American pays $10,000 a year in costs, so we really do have skin in this game. As a parent, there was a time when my daughter was receiving intravenous medication for a bone infection, and it was going to require 6 weeks of intravenous therapy. We found out after she was discharged from the hospital that now that was a outpatient bill, and we were on the hook for that. Of course, I wanted my 2-year-old daughter at home. As a registered nurse, I was comfortable hanging her IV bags, but that was a big cost that we were able to, with credit cards, able to handle. So these are real issues that affect people. Our adult son, who's 37, has autism and mental health disorders, has been on medications since he was 8 years old. Many years, those were costs that were borne by us for significant. So, in a system where healthcare providers are talking about the importance of patient-centered activities, we have got to have this level of transparency, and we have to really level the playing field. I appreciate the technical issues that were just described in the back and forth, but consumers need transparency. For your constituents, transparency is a very widely held value. So
And one of the challenges, those transparency have a cost, and those costs, my concern, might be passed on to us, the consumers. Lady Price, did you have a question on the response? Okay, all right.
Thank you.
Thank you, ma'am.
Just-
Anyone else?
I have a question
I'm
for
gonna
you.
get with the response.
Sure.
Yes, sir, Elliot Hodges. Ma'am?
Ma'am,
Oh, sorry.
you know, most of this deals with pharmacy benefit managers and so forth, and you're looking at either the retail or the whichever pharmacy to process the claim through the PBM. PBMs already know the copays, they know the costs, they have formularies, so why not just pick up the phone and call the PBM?
I think the average person doesn't even know what a PBM is. I
Well-
happen to kind of be a bit of a geek about some things, and I think it's, what I look at in talking with Mr. Levine is, I'm gonna use this example. When I go to Panera now, I kind of really don't want to see the caloric, how much the calories are on my favorite little, sweet things, or at McDonald's, etc. But that level of transparency that has been imposed upon the food agency, the food, vendors, and people have complained about it, it's gonna drive costs up, etc. But those are important transparency issues. So I think that, again, we have to really look for the average person who is spending money, their hard-earned money on this. They always come back to us as consumers and to all of us. And I think anything that we can do to really work out these issues are going to help people be better informed. And better informed patients are going to have, more of participation in their outcomes.
Thank you very much. Anyone else in the audience to speak in opposition to 2426? Or I'm sorry, in favor of 2426?
Thank you, Mr. Chairman, and members of the subcommittee. Joel Hankin from the Virginia Poverty Law Center. And as I said earlier regarding Delegate Toscano's bill, patients need more information, consumers need more information. In the pharmacy arena, it's really surprising to learn about the differences in cost between different pharmacies. I've had this experience in my own family, going to different pharmacy outlets. The costs can be quite different, and when patients are required to make certain cost-sharing payments, it comes out of their pockets, and for those people who are still paying full cost, it makes a big difference. I appreciate that there are technical complexities here, but I think we do need to move forward to give the consumers the information that they need.
All right, thank you very much. Question for the respondent? No, hang with me. Anyone else to speak in favor? Anyone in the audience to speak in opposition to House Bill 2426 as substituted?
Mr. Chairman, members of the committee, Brent Rawlings, Virginia Hospital and Healthcare Association. Certainly no issues with transparency, but just as a technical matter, looking at the draft for the first time, lines 81 through 91, the concern we would have is about pharmacists and dispensing the controlled substances in the hospital setting, inpatient setting. Not really sure if the words dispensing is captured in the practice of delivering medications in the inpatient setting or in the emergency department, other situations like that. So I think that's just a technical concern that we would want to be sure is addressed.
Thank you, sir, because I would read the same way, Brent. I don't think it's addressed. It says every pharmacist, and your guys are all licensed by the Board of Pharmacists. All right. Yes, ma'am.
Hi, Nicole Huber-Lauder on behalf of CVS Caremark, the PBM. We did speak to Delegate Levine about the bill. We are not in opposition, but just wanted to clarify. CVS Caremark is working on a tool through the NCPDP, and I want to get the acronym right, to show the cost, the copay, and everything to the pharmacist prior to the dispensing. That's not yet complete, so we're working on it, but we don't have the ability, as Delegate Hodges said, to take back the fee that's charged.
All right, thank you very much. Yes, sir. Come on
Mr.
forward.
Chairman, members of the committee, Robert Barrato with America's Health Insurance Plans. We are fully supportive of every opportunity to be transparent, especially in the high cost of drugs. We are troubled by the very thing that Delegate Hodges brought up, which is requiring the pharmacist at the point of sale to keep querying the system and racking up charges, which then just adds to the cost of pharmaceuticals and the delivery of pharmaceuticals, which then gets put back into your premiums. So if we're trying to do something like this, we gotta find a better way, and we do offer those services to our members through our PBMs to query what the cost of drugs are, through our websites and through our apps. So we would hope that you'd find some other way than requiring the pharmacist to query, to keep pinging the system and racking up the charges. Thank you.
All right, sir. Yes, sir. Come on forward.
I'm Doug Gray. I'm with Virginia Association of Health Plans, and I wanted to associate myself with Robert's comments. We are in favor of transparency. We want people to be able to look things up. That's why we're investing a lot of time and effort and money and tools to try to make it easy for people to use apps to do that. And we actually do have the ability, if you call, as the delegate has suggested, to get the prices as well. So, thanks.
All right, sir. Yes, sir. Thank you. Anyone else? Okay. Delegate Peace, you had a question, and Delegate Price is good, and then Delegate Hodges.
Well, this is complicated for a lot of people, including myself. I'm gonna ask Delegate Hodges a question. Where does the prior authorization component come into this charge on dispensing? And maybe you wanna comment about the transparency.
If there is, are you talking about the prior authorization process with the physician? So the pharmacist fills that prescription, actually goes through that switch company, it's denied, there's a charge right there. Then we have to get that prior authorization. It's actually done electronically to the physician, which can take anywhere from 1 day to 7 to 10 days before we actually get that response back. And typically that response may or may not come back to the pharmacy because the patient actually owns that prescription and could take that prescription to any pharmacy they want to. So the patient is often notified and not the pharmacy.
That was my question.
And they may or may not be notified.
When does the patient find out in that process?
It's gonna depend on the insurance company.
It's very good.
I completely am acknowledging my privilege as someone with wonderful insurance, but when I call my pharmacy, and I have quite a few medicines, when I call them, I ask them how much is it gonna be. Is that, the sense of it is that because I do have the insurance that I can find that out prior to the pharmacist collecting fees. I have not encountered this problem that we're trying to solve.
I'd like to partly address that because I have called, in fact I called when I first joined the House Delegates and I said, hey, if I'm on this insurance plan, because I wanted to know what a common cost for a very common cholesterol drug was. And I said, if I'm on Anthem, how much does it cost? I'm on Aetna. They said, we can't tell you that information. And they would not tell me the information. I said, how am I going to find out the information? They said, well, you join the plan, and then you order the drug, and then we dispense the drug, and then we send you a bill. And I said, well, what if the cost is too high? They said, well, in 1 year, you can change your plan. That was probably the genesis of this bill, although certainly I've heard from many people, they just don't know how much these things are. But because they get to find out prior to the bill, under this bill, prior to being dispensed, they can decide, if I order a steak, I know how much that steak costs before I get the steak. Now, the concern that Delegate Hodges raises, or the concern, I hear pinging the system sounds like I'm going to check the price 20 times. If they check the price, and the price is reasonable, and the patient buys the medication, there's no extra charge from this bill, zero, because they had to pay it anyway. Now, if they check the price, and the patient says, this is way too much money, I'm not going to spend $200 on my medication, I'm going to use GoodRx, I'm going to go to the pharmacy down the street. Delegate Hodges is right, there is a charge, something like 2 or 3 cents per prescription. And that matters, which is why the pharmacist asked me to provide Section F, which says that any contract between a pharmacist and a PBM says that if you check the price and you don't dispense the medication, you got to refund that.
Okay, I think we got it. Delegate Hodges, you have
So,
another question, sir?
kind of
We need
comment
to
to
sort of
follow
wrap
up
this
on that
up.
process. It's not quite that easy. Number one, you need a prescription to be able to process with the physician the drug, the quantity, how you're taking it in order to process it. The charge is probably 7 to 9 cents on the back end for each transaction, which the pharmacy actually would bear that cost, which is non-refundable, because that's through the switch company, not the TBM.